Okay, yeah, so just to get started with a little bit of housekeeping then. So I should start by introducing myself. I'm Carrie Purcell, the PI on the SASS project. I just want to thank everyone very much for coming. As I say, I know some folk have been struggling to get in this afternoon with a couple of technical issues, but I see a lot of people are managing to join us. So it's really lovely to see so many people with such diverse interests and expertise, and we've got sort of policy, research, practice, activism, folk from all over, loads of different locations as well, which is really exciting. So yeah, and as I say, a much bigger kind of spread of people than if it had just been a face-to-face event. So there are some advantages to the push online, I guess, for something like this. So yeah, so we're really excited to share some of the SASS project outputs with you as the study nears its end. We are, just to be aware, we are recording today's session so that we can make it available on the website later on, and particularly for anyone that hasn't managed to get in today that did want to attend, and I know some people that did want to register that couldn't make it. So we will circulate a link and put that on Twitter as well, that once we've got the recording uploaded. And we have got a packed schedule, and we are running a little bit, sort of 10 minutes behind in starting today. So, but we do have a very able chair to help keep us on track with our timings. So I do hope that we'll still have plenty of time for discussion at the end of today's talks. Since a big part of the aim of the webinar today is to launch our new website, what I'm going to do is just give you hopefully, if you can see that, a sneak peek of the website along with the web address. So it's sassproject.org.uk. Please do have a look at that this afternoon if you can. The intention with the website is really for it to act as an archive of our study outputs, and outputs from the original primary research studies that we reanalysed in the SASS project, which I'll say a bit more about shortly, and to link to other relevant activities and publications and whatnot. So we'd love to hear your feedback on that today. But I'm now going to hand over to our chair for this afternoon. So I'm delighted that we have with us Dr. Anu Kumar, who is the President and CEO of IPAS and a key member of our Project Advisory Group. I'm sure many of you will know Anu's contributed a huge amount to debate and work around abortion stigma. So yeah, enough from me. I'll hand over to you, Anu, now.
Thank you, Carrie. Thanks so much. And thank you everyone for joining, and thanks for your patience with the technology. It is always a challenge to manage it. So I'm delighted to be here today. And for those of you who don't know IPAS, we are an international NGO that focuses on increasing access to safe abortion and contraception. We work primarily in Africa, Asia, and Latin America. And we've been thinking a lot about abortion stigma and doing a lot on abortion stigma for over a decade. Back in 2009, colleagues and I wrote a paper called Conceptualizing Abortion Stigma. And I think it was one of the first papers on this topic. We did it because we were doing actually IPAS's organizational strategic plan, and our colleagues around the world kept saying, you know, stigma is a really huge barrier. It's a very important issue, and you know, we must do something about stigma. And so we went back and we went to the literature to see what we knew about abortion stigma, and we found that there was actually very little on the topic. And so we began thinking about it and wrote that paper, but then went on to do some really interesting research on the topic. The paper, I think, and the work that we started back then really hit a nerve, because it sparked interest in this topic from researchers, from students, advocacy organizations, and it led to a lot of activity, from everything from media campaigns to scholarly work to the creation of Inroads, an international network addressing abortion stigma. IPAS itself developed an early measurement tool for measuring abortion stigma. We did multi-country research and incorporated anti-stigma activities in our work around the world. And our colleagues around the world did much more. So there's been a whole lot of work already that's taken place on abortion stigma. And what's interesting and exciting about this webinar and the SASS project is that we are now pivoting from a conversation about stigma as a barrier to abortion, to normalizing the experience of abortion and how we can facilitate that care. And the SASS project also does, does the job of bridging what are often gaps between research, policy, and practice. And I think you'll see that in the presentations that you'll hear this, today, but also in the website, which is really intended to share the research, but share the research in a way that can be understood and applied by a range of organizations, individuals, policymakers, et cetera. So we're going to go on a bit of a journey, a time journey as well, when we hear from our panelists. We're going to hear about abortion stigma and normalizing abortion in the past, its current state, and I mean current state right now in terms of the pandemic, and as well as the future. And so as you'll hear from our panelists, I think we have reason for being optimistic that abortion care can be considered just another procedure and not perpetually singled out for medical or legal scrutiny. It can be provided without apology and in a caring manner as part of mainstream medicine and as part of a person's reproductive journey. So we'll start by hearing from Carrie, from Dr. Purcell, about women's experiences with abortion. We'll move on to learning how providers see it from Dr. Maxwell. Then we'll hear from Dr. Bloomer about how lessons from this project are being applied in Northern Ireland. Then we'll turn our attention to the impact of the COVID pandemic on abortion care when we hear from Dr. Rowlands, before we wind up with Dr. Hoggart, who will be sharing with us information about a new UK charity that she is launching to help normalize abortion. So just a quick bit of housekeeping before we get started. Please do put your questions in the chat function, and indicate, if you can, where you're based or what institution you're representing and where you work, and let us know who your question is directed to. We'll try to take questions in between the talks. We have about a minute or two between panelists, but if we can't get to them between the talks, we do have hopefully a discussion session, and I hope we'll be able to have time to answer some of those questions at that point. So, and I'll be monitoring the chat in order to see that we can answer some of your questions as they come along. So let me start by introducing Carrie Purcell. Carrie is a research fellow at the MRC CSO Social and Public Health Sciences Unit at the University of Glasgow, and she leads the SASS project. Carrie is a medical sociologist specializing in qualitative and mixed method health research and evaluation. As the PI on the SASS project, Carrie has guided the only qualitative secondary analysis study to date to look at abortion across the UK's different jurisdictions. Carrie has conducted a range of abortion-related projects over the last decade, including women's experiences of later abortion, more than one abortion, and women and health professionals' experience of early medical abortion. Her research has been widely published in journals including Sociology of Health and Illness, Culture, Health and Sexuality, and BMJ Sexual and Reproductive Health. Carrie, let me turn it over to you now.
Thanks, Anu. Thanks very much for the introduction. So yeah, what I want to do this afternoon really is to give you a whistle-stop overview of what the Sexuality and Abortion Stigma Study has been over the last 3 years. Some of you might be familiar, I know, but some not. I then want to introduce the first of our 2 briefing papers, which we've just published, which looks at normalising abortion from the perspective of women who have undergone the procedure. So the study was designed to re-examine a range of existing qualitative data sets relating to abortion from the UK, from studies that were carried out between 2008 and 2018 in Scotland, England and Northern Ireland. The studies there were studies that myself and my co-investigators had all been involved in with other colleagues based in the UK, and from discussion we knew that there was quite a lot that we could still do with the data that we hadn't yet had the capacity to do. So we designed the study as a qualitative secondary analysis study, which is an approach that can really maximise the value from existing data, and it can be particularly useful in the context of what you might broadly term a sensitive issue. So it was initially designed as a one-year study, though, as I say, we started just over 3 years ago, and we're still going now, but just a few months left. We're really grateful to the Wellcome Trust for their continued support for the project. So we brought together 11 data sets, which included accounts of women, health professionals and educators working in abortion. These were interview studies, focus group studies, and included a total of over 400 individual participants. It was quite a huge amount of qualitative data that we explored in a range of different ways. I won't go into detail really about the methods today, but Karen and I would be more than happy to discuss with anyone that would like to know more in terms of the actual approach to analysis that we took. I want to talk a little bit more about the findings today. Our initial aim was conceived in response to a Wellcome Trust funding call relating specifically to sexualities and health. We aimed to explore how useful a QSA approach would be to further understanding of abortion stigma as it relates to female sexuality. While our starting point was the continued stigmatisation of abortion worldwide, and specifically here in the UK, as the study progressed, we became interested in moving on from understanding stigma to exploring normalisation and the normalisation of abortion, and how we could use existing evidence to further the debate in that direction. We were really interested in how we could contribute to creating a space for normalisation and building on the ways that abortion is talked about by those who have undergone the procedure and those with frontline experience of providing it. So, in terms of our key findings, in methodological terms, a key finding was that you definitely cannot do everything that you might want to do with such a huge amount of data in a relatively small project. But some of the key points that we did establish as part of our analysis of women's accounts was that abortion is talked about as being positive and right. And we identified challenges to abortion negativity, but these were relatively rare in the data that we were looking at. So to look at the first one of these, while abortion is often framed negatively as a social problem or something that people might disagree with, it is not experienced in this way by everyone who has one. So we identified key examples from our data where abortion was described as a positive option or life event, as the right choice, and even for some people as something that made them happy in the sense of what bringing that pregnancy to an end meant for them, the implications of that. You can see just in the quote here an example of that. So what we're suggesting is that non-negative framings of abortion counter the dominant view that abortion is automatically, by default, a negative thing, a problem, and that these instances of positive or neutral language might be built upon. Having said that, we also found that strongly positive accounts of abortion were relatively rare. They did appear, where they did appear, positivity or neutrality were often still intertwined with very negative language. So you can see from the second quote that I've got here, the participant talks about it being quite a good experience, but actually then goes on to use quite negative language in terms of what she didn't experience. So she didn't feel ashamed or bad or guilty. This was a really common occurrence in the data that we looked at, that participants used quite negative language to explain what they didn't feel about their abortion experience rather than more positive language to describe what they did feel, which for us highlights an absence of readily available language relating to abortion that is not negative. So what does this tell us? Our interpretation, what we're suggesting this highlights, is the sheer complexity of abortion experiences for one, and that ambivalence might continue to be a common, or if not the most common, response to abortion. That some people may only feel able to talk about abortion in ways that are currently the norm, so i.e. that it is a difficult and a negative thing, and that talking about it in other more positive ways may not always be seen as an option, even if that's what more accurately reflects their experience. And this is partly because it's hard to do so. It's challenging to go against powerful social norms, particularly at an individual level, where, you know, that's where most of the participants in this data that we were looking at were speaking from. We observed a conflict between the ways that women talk about abortion in general, as a positive option which should be available for everyone, and abortion as their individual lived experience, which was in different ways challenging for them as an individual. And understanding and accepting these two viewpoints and that they can coexist, i.e. that it is a good thing to have readily available, but the aspects of it may be difficult or challenging, is key to recognising the complex reality of abortion as lived experience. So I'd just like to end, I've probably talked for too long already, so I'd just like to end with a couple of points on the implications of this analysis for research and practice, which would be really great to get your feedback on later in the session as well. What we flagged primarily is that the dominance of negativity in the language surrounding abortion needs to shift to offer women a fuller range of options in describing and understanding their experiences of abortion in different terms. We're always keen, as Anu alluded to in the introduction, we're always keen to think about how we can link up our research findings with policy and activism. And I'm looking forward to an event that Inroads are hosting tomorrow on bringing about narrative change, to hear about some of the work the Inroads members have been doing in that area more recently. But thinking specifically about a UK context, we need a shift away from negative framings, which here within our context includes within our National Health Service. Karen's going to say a little bit more about the role of health professionals in that respect in a moment. But this will help to normalise abortion, so that is to broaden out understanding of it as a normal, essential reproductive health care provision. And just to flag that basically what I've been talking about today, what I've been presenting, is available to download from the website as a 2-page briefing paper. And also, if you do want to read more in depth about some of the arguments that we've been making there, there is also the paper that we've published in Culture, Health and Sexuality, which you can also access through the website. That's everything from me. Thank you.
Thank you so much, Carrie. I think your work actually does also corroborate other work that says that women, from UCSF and elsewhere, that women do feel relief and do not feel regret about their decisions to terminate a pregnancy, and so we do need better language to describe that experience, so that they can actually articulate those positive experiences in a positive frame rather than always from a negative frame. So thank you for that. Let's turn now to Karen Maxwell. Karen is a research assistant also at MRC CSO Social and Public Health Sciences Unit at the University of Glasgow. Karen has worked on the SASS project from 2018 to 2019 and led the day-to-day management of the project, including coordinating data sharing, analysis, and project events. Karen has co-authored 2 peer-reviewed publications based on findings from the SASS project, including a first authored paper on how health professionals contribute to normalizing abortion, which she's going to talk about just now. Karen is currently part of the team that's conducting the 4th National Survey of Sexual Attitudes and Lifestyles in the UK. Karen, let me turn it over to you now.
Thanks very much, Anu. That's fantastic. So hi, everyone. My name is Karen Maxwell, and as Anu mentioned, I'm a public health researcher working at the University of Glasgow, and I've worked with Carrie on the SASS project since its very beginning. So the bit of the work that I'm going to talk about today relates to the part of our work which focuses on health professionals and the role that they can play in challenging abortion stigma and helping to normalise abortion. So the reason we wanted to focus on health professionals is because kind of worldwide now there's an interest in combating and reducing abortion stigma. And obviously health professionals can have a major role to play in this through the way they frame their work to both the women that they treat, but also to people, significant others in the world around them. And so we were really interested to understand how healthcare providers talked about their work, and what were the challenges that they faced in conducting their work in abortion care, sort of day-to-day, the everyday challenges. And we were also interested in how did they reject or resist negativity, and in particular, how did they talk in positive ways about the work that they were doing. So our findings uncovered 4 key themes in terms of the way healthcare professionals talked about their work. And these were encountering resistance to abortion from others working in sexual and reproductive health care, contending with negative socio-cultural narratives of abortion, enacting overt positivity towards abortion provision, and presenting abortion as part of normal routine healthcare. And I'm just going to be focusing today on two of these themes. These are the themes that really relate to working within the healthcare setting. So if you're interested to read more about the other themes, you can read our paper, or you can read the shorter 2-page briefing paper, which, as Carrie mentioned, is on the website, so you can find those there. So talking about resistance, I thought it would be good just to start with a quote from one of our participants. So this was a nurse working in abortion care in Scotland, and she highlights the challenges of working in abortion care with a perceived lack of support from colleagues elsewhere in women's health. So she said, it's opened my eyes a lot about other people, you know, even senior staff, really knowing now by their behaviour and their attitude and their response of either support or non-support towards us. And I know what their personal feelings are about termination. And it just surprises me that any of these people work in gynae. They don't mind saying that they won't be involved in it, but I find it very difficult how people can work in gynae and not support women. So as the quote illustrates, participants often describe experiencing a lack of support for the abortion service from colleagues working elsewhere in women's health. And they described experiencing openly expressed negativity and sometimes even outright hostility. And you can see that all this leads to a situation where the abortion service feels more and is experienced as more stigmatized than other aspects of sexual and reproductive health care. And this was really felt really strongly by our research participants. So one of the ways that healthcare professionals can combat this was in the ways that they presented abortion to others. And this leads us on to our next theme, which is about presenting abortion as part of normal routine healthcare. So I'm just drawing on quotes from two of our participants here. One, a nurse, another in a different part of Scotland, talking about how abortion care, she sees it as really just another part of her job. So she said, you know, it's just a part of my job, as in if someone came in with a miscarriage, I would deal with that. That's part of my job. If someone has a hysterectomy, then that's part of my job. And that is how I see it, talking about that's how she sees abortion care as similar to other aspects of her job in sexual and reproductive health care. And similarly, we've got a clinic manager in England talking about how she sees the service as a valuable and essential service. So again, I think that working the role that I work in, we have a whole array of reasons why women will present to us. And I think that it's a valuable service that should be provided for women. So this highlights what many participants said to us was that they viewed their work as similar to other parts of routine and essential sexual and reproductive health care. And therefore they talked about it in similar ways to how any doctor or nurse or other healthcare professional would talk about working in any other area of healthcare provision. For example, they talked about respect and dignity that patients could expect to receive, and also the quality of care that patients could expect to receive, and things like the timeliness of service provision. And all of those things are things that you might find in any way that a healthcare professional would talk about any other aspect of their work. And you could see that this was linked very closely to their view of abortion care as being a valuable and essential service for women. And so this therefore links back to how hard it would be then for those working in abortion care to feel resistance from others when what they saw themselves as doing was really providing a valuable healthcare service that was very routine for them and trying to care for the women that they treated on a day-to-day basis. So what can we take from this in terms of recommendations from our work? Well, I think it was very clear that negative attitudes towards abortion still persist within healthcare settings, and that these need to be challenged, particularly in order to destigmatize abortion for not just those accessing the services, but also for those providing the services. And also that healthcare professionals can clearly play a role in normalising abortion through the ways in which they talk about their work and present it to not just the women they treat, but also others all around them. But to say, though, that they shouldn't be doing this alone, it's not that they should be standing alone and trying to break down abortion stigma. They need to be supported to do this through systematic change within healthcare settings. So appropriate support and structural change are really necessary for normalisation to become embedded within healthcare settings. And our analysis suggests that a key way to do this is by framing abortion as ordinary routine healthcare. And this would apply to not just how it's talked about by healthcare providers, but also how it's considered in terms of health service provision and in policy. So as Carrie mentioned, there's a 2-page briefing paper that can be found on our website, and the paper itself is published in BMJ Sexual and Reproductive Health if you wanted to read further. Thanks very much for listening.
Thank you so much, Karen. We have some a couple of questions in the chat. If I could take those now. Carrie, one of them is for you from Rachel Wilson-Lowe, who's a student at the University of Glasgow, a PhD student, Carrie's student, your student, so I presume you know each other. Her question is about whether you encountered in your data examples of women feeling guilty about not feeling guilty. Sort of circular, but nonetheless, because the dominant frame is that you should feel guilty about having an abortion when you don't feel that way. Do you feel guilty about that? So in her data, she's saying that has come up, and she's wondering if that has come up in yours, Carrie. Carrie, do you want to take that?
Yeah, sure. Yeah, thanks, Rachel, for the question. I think definitely that is something that we've seen across the data, and I think Karen will probably agree with that as well, that there is definitely a sense of, from a lot of participants of, like you say, guilt for not feeling guilty, expectations that they'll be treated negatively by health professionals when presenting at services, all those sorts of, kind of indications that really speak to the negative framing overall of abortion and what people are going to expect when they're, either seeking that health service or talking to anyone about it, talking about their experiences. I think it is definitely something that we have seen quite commonly across the data.
Interesting. And then we have a series of questions, or several questions about, I think maybe Karen, you would be best placed to respond to them, about how to promote positive norms about abortion when there is such negativity associated with it. So one of our participants says that Edinburgh Council has recently supported the introduction of a buffer zone. Are you aware of any other medical procedures that are picketed? I think we can probably safely say no, that is very unlikely that any other procedures are picketed. So how can we see, how can we tackle the negative narrative? And then another colleague, Leanne, who's a lead communications at NHS Lothian, says that her Swedish colleagues always wanted to frame this as a positive decision, but it's hard. And so cultural differences, no doubt, are important, again, in thinking about communications and social norms. And then finally, Karen, do you see the location of abortion services as contributing to the presentation of abortion as normal? And that's from Rebecca Blakelock from BPAS, Blaylock, excuse me.
Yes, well, thank you for those questions. I mean, I think just in relation to that first point about the picketing and the way it's presented, we have consistently said this in our meetings, you don't get people picketing or having emotional reactions to really almost any other aspect of healthcare. And that makes it different and difficult, but what we're trying to say is that it needs that kind of framing of abortion care needs to be broken down. And I think there's a large movement for this now online, that the ways in which women talk about their abortions and the way in which healthcare providers talk about providing abortion, there's a big space for being able to say, this should just be another part of everyday healthcare, and it needs to be seen that way. So you'll see the tag trending on Twitter or whatever, abortion is healthcare. But despite the fact that many of us and many people feel that way, does not mean that the stigma goes away, and does not mean that, everybody will see it like that. So I think there's still a lot of work to be done there to kind of break down those negative framings. And I think in terms of, framing it as a positive decision, despite the fact that so many women might feel that it was something they struggled with, or it was a hard decision for them individually, again, that's something that we wanted to say, we're not at all saying that abortion is a normal thing for someone to go through. We're saying it should be part of normal healthcare. But for an individual, these decisions are often difficult, and people have a range of complex and mixed emotions about going through a procedure like that. And as they should do, women, people experiencing abortion, should be entitled to feel however they feel about their decision. And I think we just need to create a space where people have language to be able to discuss their abortion in positive ways as well as negative framings. And I think that's what Carrie and my work has uncovered, and what needs to be there is that there isn't this positive language that is available for use. And there needs to be something there to fill that space, so that when you're talking about your abortion, you don't need to always say, I didn't feel blamed, I didn't feel guilty, because that's the only framing at the minute that's available to you. And just very quickly, the last one about, did we see a difference between the location of abortion services? Yes, I think we did, because I think that those working in the NHS came up against more resistance, because those working in the independent sector kind of were more closed off from that that kind of resistance of colleagues working in the NHS, whereas those working in the NHS often had to, for example, refer a person who was going through a mid-trimester abortion to maternity services, for example, and midwives then were negative towards them. And that kind of aspect of the care was less prominent in the independent sector professionals' accounts. So yes, definitely a bit of a difference there.
And then finally, let's take this final question before we move into Fiona, which is about religious beliefs. And did that come up in terms of increasing stigma for healthcare professionals in the healthcare settings? Karen, if you could just respond to that real quick, and then we'll move on to Fiona.
Yeah, well, totally, absolutely, and in both ways. So we did have a few participants say things like, I am religious and I feel strongly that I do a good thing in what I do in terms of like the healthcare that I provide for women. But then they would say things like, but I also feel strongly that I would receive criticism, or I would receive stigma from friends if I revealed to them what I did. So one of the themes I didn't talk about was how people talked about their work to friends and people outside of the healthcare setting. And in particular, a lot of people kind of minimized what they did. So they'd say they worked in sexual and reproductive healthcare as opposed to abortion services, or they'd be careful about who they revealed their full extent of their work to. But again, feeling proud of what they did, they didn't feel that they were doing a bad thing. It's just literally about reducing the impact on them of people having to defend their work, or the feeling that they need to defend their work. Right. So yeah, religion did come up.
Yeah, religion does come up, and yet certainly in IPAS's work around the world, Catholics have abortions, Muslims have abortions, everyone has abortions. So religion does matter, and yet at the end of the day, when a woman wants to terminate her pregnancy, she will terminate her pregnancy.
Yeah, and Christians are healthcare providers too.
Exactly.
So that was that's what we saw as well. They feel they're doing good work and caring for women. So.
That's right, exactly. So clearly we can have a long conversation about this, which we would like to do, but let's move on also to hear from Fiona. So Fiona Bloomer is a senior lecturer at Ulster University in the School of Applied Social and Policy Sciences. Her research centers on abortion and its intersections with policy, stigma, and faith. So good timing. She has led on studies of abortion as a workplace issue, the political discourse on abortion, the translation of human rights norms into discourses on abortion, as well as collaborating on a study of adult community education on abortion. Fiona's research findings have been published in a range of international journals, and she is co-author of the book, Reimagining Global Abortion Politics, A Social Justice Perspective. Fiona is regularly called upon to provide expert opinion on abortion policy to the media, as well as to national and international inquiries into abortion access. Delighted to have you, Fiona. Please go ahead.
Thank you, Anu. In my presentation this afternoon, I want to focus specifically on Northern Ireland and present an overview of how the data has been used so far in that context. So first of all, an overview of where we're at in Northern Ireland in terms of, sorry, I can't move, in terms of the context of recent abortion history. So we live in it's a very morally conservative society. We have poor or non-existent being the norm, relationship and sexuality education. Sexual and reproductive health services are under-resourced. We had very restricted access to abortion, which was based on the 1861 Offences Against the Persons Act. And in the year before decriminalisation, that amounted to less than 15 abortions carried out under the National Health Service in that year. We've had a very lengthy activist and NGO campaign to bring about change, and also a number of court cases. The United Nations Cedaw inquiry was published in 2018, and they made a series of recommendations to improve relationship and sexuality education, sexual and reproductive health services, and access to abortion. And then following the efforts of Stella Creasy MP, abortion was decriminalised in October 2019. We had regulations published on the 31st of March 2020, and interim services then began in April 2020. And these have largely centred on providing early medical abortion. Over 1,000 women and pregnant people have been treated since April 2020. and those that need surgical abortion or beyond 10 weeks largely have to travel to England to access services. So combined, I suppose that the restrictions, the stigma, and all of those weaknesses in the system that we have, abortion stigma has been common in both media, political, health professional and public discourse. The normalisation of abortion has been advocated by Alliance for Choice. They're the main activist group in Northern Ireland, and that's happened through their engagement with politicians, with the media, designing and delivery of education programmes for trade unionists, for communities and schools, and all of that has been very much informed by the SASS project. This is a quote from Trade Union Evaluation Project, and you'll see here this individual talks about, I never thought of abortion as a workplace issue. I'm a manager in human resources. I deal frequently with staffing matters, and having completed the session, I'm genuinely surprised at the information presented and realised it will have an impact on the people that I have managed and will continue to manage. And there is a clear need for this information considered when it comes to employer policies within organisations. The normalisation of abortion has also been supported by health professionals, the Royal College of Midwives, Royal College of Obstetricians and Gynecologists, Doctors for Choice NI, which was set up in June 2019, and the newly formed Northern Ireland Abortion and Contraception Task Group, NIACT, and that's a combination of representatives from the Royal Colleges, service providers and academics. And again, this has occurred through policy papers, training, research, and also the SASS outputs feature in the NIACT report. The NIACT report is due for publication on 31st of March of 2021. And it sets out what needs to happen to respond to all of the Cedaw recommendations in terms of education, services and abortion. Throughout the coming months, we will also be continuing the training of health professionals and also continuing work with Alliance for Choice to normalise abortion. And that includes the development of an abortion doula training programme, which has had its first run in spring, summer of this year. And again, all of that, we will continue to rely on the SASS outputs to inform that. So that's a whistle-top tour around Northern Ireland and what we've done with the SASS project. I'm happy to answer any questions. Thank you.
Wonderful. Thank you so much, Fiona. It's great to see it being utilized in that setting and more to come, no doubt. So yeah, I was just suggesting, Karen, there are a couple of questions in the chat about medical education. So maybe if you could take those in the chat, and then we'll continue on with our panelists and see what other questions come our way in the chat as well. Thank you everyone for those questions. We appreciate it. And I'm doing my best in trying to keep track of them. But please know that we hopefully will have time also in the at the end here. So let me turn now to Dr. Sam Rollins. Sam is a visiting professor at the Center for Postgraduate Medical Research and Education at Bournemouth University. Sam has a background in clinical practice, first as a GP and then as a community sexual and reproductive health specialist and abortion provider. Sam has published widely on abortion-related issues, including a range of aspects of service provision and care, and he has edited Abortion Care. And he is currently secretary of the British Society of Abortion Care Providers. Sam has previously held senior roles in the Faculty of Sexual and Reproductive Health, Royal Society of Medicine section, and FIAPAC. Sam, over to you.
Sorry, I just needed to unmute there. Apologies. Good to have you all listening. My talk goes a bit beyond the actual research into applications of the research. And what I'm going to do is summarize what has been a radical transformation of care in the context of severe pressure on other health services due to COVID. And you will have noticed already that both Carrie and Karen talked about, they mentioned the word essential. And I think what I'm going to say reinforces that abortion is essential and cannot be sidelined. So there are three main areas of change in response to the pandemic. Remote consultations, whether by phone or video link. No routine tests. Again, these will be done selectively. So scanning is only selectively. STI testing can be done by post, and pills delivered or collected. This includes mifepristone, whereas before the regulation was only allowing misoprostol at home. Again, for all these three things, there's plenty of evidence to back them up. So in Britain, temporary measures were brought in after, I might say, considerable pressure put on health departments. Fiona has already mentioned that Northern Ireland is really in a separate category, which is very unfortunate. So a majority of countries have no such regulations. You can see here just a handful of other countries have these temporary COVID regulations. Obviously, in other countries where decriminalisation has already taken place, Australia, Canada, New Zealand, there is no need for these kind of regulations. So massive changes last year after 30 years of early medical abortion with everybody having routine scans, complete change in practice, no routine scans. And I may say that we were very encouraged by the experience of general practitioners in the Republic of Ireland who have been conducting medical abortions without routine scanning. So what this means is that literally tens of thousands of scans, or tens of thousands of women avoiding needing to have invasive scans. So this is really one of the most groundbreaking research studies that we've had in recent years. So a British cohort study has just been published relating to data from 2020. All the data came from the three major independent sector providers. The sample size was over 55,000. Analysis was done by Abigail Aiken in Texas. And as you can see on this rather beautiful infographic, there were three main findings from the study. And you'll see here that telemedicine, no test telemedicine is just as safe, equally effective, and has better accessibility. So just look here at the difference, over 4 days less waiting on average. And we know that minimal delay is a key priority for service users. The same study, here are the 5 authors in BJOG, showed excellent satisfaction. So really all this provides incontrovertible evidence that the temporary regulations should be continued in the 3 countries, and many of us have been sending in submissions to public consultations that have just closed, and we're going to hear the outcome in about 3 months' time. So really these service innovations were down to chance in a way, and activists, clinicians, others seized the moment but we really need to think a bit more widely. Coming back to normalisation, these are some of the attitudes and policies that that we need to modify. So we need decriminalisation, destigmatisation, as we've been already talking about. And we need for the providers to empower the users. So what does normal abortion care actually feel like? We've already had this explained to us: unexceptional, positive, fully integrated into mainstream healthcare, and in extraordinary times like we're going through at the moment, maintained as an essential service. So this next slide is a vision for the future that Dr. Geoffrey Whale of Bath Spa University and I have proposed that we aim for. So as well as normalisation, we need person-centeredness, we need choice, and when we're talking about choice, this means whether to have surgical or medical procedures, the setting, and the specific timing. The setting can often be at home, and travelling is avoided. And it's interesting to reflect that whole books have been written about women travelling for abortion. Medical advice and support is constantly in the background. And I suppose you could summarize all this by saying that services are humane and dignified. Thanks.
Thank you so much, Sam. Very interesting and very interesting kind of guidepost for the future as well in terms of what we're aiming for. I should also note that the pandemic has provided an opportunity, I say that in quotes, also for IPAS's work in terms of the innovation that you mentioned for telemedicine in other parts of the world as well. And I'll just put some information in the chat box about that, where we've seen telemedicine in other locations. So but you're quite right that we're worried whether those gains will stick after, hopefully after the pandemic. So we did have a question early on for you, Sam, about whether, from Audrey Brown, about asking whether you thought that the governments in the UK have actually contributed to reinforcing the stigma by holding public consultation about medical abortion at home, rather than making a decision based on evidence and professional guidance.
Yes, I suppose they have to be seen because of the they get a lot of anti-choice stuff coming in. I suppose they have to be seen to be consulting. Unfortunately, it's not like there's another consultation going on at the moment. On the medical and the drug regulator is talking about progesterone-only pills, and they've actually already virtually made the decision, and they're just asking for people to confirm. But the abortion consultations are really pivotal because there will be arguments coming in on both sides. But I think you can rest assured that plenty of people put in pro-choice arguments. Right.
Okay, thank you so much. And I see a question here also from one of our participants, Rishita Nandagiri, a postdoctoral fellow at London School of Economics. Rishita, I think I'm going to save your question for the discussion because it's quite meaty and there's a lot to it. And so I think we will want all of our panelists to contribute to that one. But so let me just then move on to our final panelist, Dr. Leslie Hogart. Leslie is a professor of social policy research in the School of Health, Wellbeing, and Social Care at the Open University. Leslie specializes in qualitative research, and her interests are focused on reproductive health, abortion policy and politics, teenage pregnancy and motherhood, and sexual health. Her recent publications include work on fertility knowledge, abortion stigma, and contraception. Leslie is an associate editor of BMJ Sexual and Reproductive Health, and her research is firmly based on women's experiences. Her public engagement work utilizes storytelling to convey powerful messages. Her work on understanding abortion stigma has resulted in the multimedia My Body, My Life traveling pop-up installation and website. And as of 2020, Lesley is leading development and evaluation of the new abortion support charity, Abortion Talk, about which she will, which she'll present to us in this session. Lesley, please go ahead.
Thank you, Anu. Thank you, everybody. So as just mentioned, I'm going to be talking about Abortion Talk, the new charity. I'm also going to be talking about a research project that we're undertaking at the moment on abortion experiences during COVID. And both these projects are certainly can be seen as a continuation of the work of SASS. They involve the SASS team members. Somehow moving on, managed to mute myself. Sorry, everybody. So first of all, the abortion experiences during COVID project. So as Sam has mentioned, there is a very large piece of work that's already out, a quantitative piece of work on abortion experiences during COVID during the last few months. And that's not the only study. There's several other studies coming along and publishing at the same time. So we started off with a very broad aim in this project, which we started some time ago, which was to explore women's experiences of abortion during COVID, with particular attention being paid to the new mode of delivery. And as I say, it's not the only project. So what did we want to add to existing research and research that's publishing right now? What is it that a qualitative study can add to that, very large and very robust quantitative study? Well, I think that what we're trying to do, and we're still halfway through, is to really think about acceptability. So the quantitative studies show efficacy, safety, and acceptability, high levels of acceptability. What we want to do is to look into acceptability a bit more, think about what is it that makes the new service acceptable? What is it that makes it not acceptable, maybe, for albeit a small minority of women? What might make it more acceptable for women for whom it has not been a good experience? And how do people feel, for example, if their choice of method or choice of place has been limited? Is that okay for everybody? It might not be. And what can we learn more about person-centered care and how person-centered care might work? In particular, we're interested in the idea of supported self-care and how supported self-care may work well, it may work better. So in other words, we have something that's working in the UK, it's working really well, but we're interested in continual improvement, how it can work better for everybody who's using the service. We haven't finished yet, so I can't give you answers to all these questions that we're posing, but I can give you a bit of a glimpse into the range of experiences that we are being told about. So I'm just going to bring up a few quotes now. So this is not such a good experience, and I don't want to dwell on this because I know that this is the sort of experience that is not the experience of the majority of women, and that's the same in our study, but it's certainly somebody's experience. And this participant was absolutely adamant that she would prefer not to have a medical abortion if she were to have another abortion, and she would certainly prefer for it not to be at home. She was, for her then, it would be very important to retain that choice that Sam talked about, the choice of method and the choice of place. This participant, well, you can read the quote for yourselves. I think you can see this feels to me like a really good example of supported self-care. It feels like a really good example of the type of person-focused care that Sam is talking about, somebody who's very comfortable and confident having her abortion at home by herself, but is really very pleased that there's somebody on hand 24/7 if needed, and very pleased about the constant reassurances about that. So finally, just some more themes that are coming through. Not surprisingly, negativity was evident, and this reminds us of the whole range of emotions and the negative language that had been used we had recognised in the SASS project. The shame and the self-blame associated with abortion-related stigma that we are so concerned to challenge and to move beyond and to think about normalisation. And it reminds us, it certainly reminded me, I hadn't done any interviews on abortion for quite some time before this project. It certainly reminded me why we're working in this area. And it reminded me that there's still work to be done around abortion and abortion stigma. And that brings me neatly to a new abortion charity, which I'm not going to take all the credit for this, no matter if people keep introducing me as the person who's starting the new charity. That's not really the case at all. There's a group of activists, providers, researchers, including our SASS team, who've been involved in talking about and setting up this charity. We worked to get some Pump Prime funding, and we're now going to fundraise to keep the charity going. We've got a brilliant project manager we've just recruited, Kelly O'Dowd from Northern Ireland, and we've already got advisory group members, trustees, and people already starting to volunteer to work for the charity. So this is a screenshot of the website, which is very, very early days, but it gives you an idea of what the charity is aiming to do. Really focusing around providing a space for people affected by abortion to talk about their experiences, and supporting access to safe legal abortion as essential healthcare and as a human right. So continuing the work really around normalisation and around working anti-stigma work. So that's what we want to do, and this is how we're going to do it. We hope. This is the plan. We really, we've only been going a couple of weeks, so it's very early days. So you can see from these bullet points of what we hope the charity will do, that there's two main areas of activity and they do overlap. So the first 2 points are really around providing space for discussion and providing resources. And these are for people who would be experiencing and affected by abortion, and we already have quite a few volunteers for the helpline, so we'll be providing a helpline. We still haven't decided whether we're going to call it a helpline or a support line. That's an ongoing discussion. And the second set, bullet points 3 and 4 then, are really working with professionals who are involved in abortion care, and this is very much building upon the work that Karen has presented today, to shift away from those negative framings, to work around, in particular, provider share workshops to help shift that language, and to work around values clarification as well. We actually have the first provider share workshop booked for colleagues in Homerton Hospital working in the abortion service there. So that will be our first activity, and we do hope to get the helpline up and running soon. So I'm going to leave it there, but I'll be very, very happy to take any questions on either the project or the charity. Thank you.
Thank you so much, Lesley. Very exciting, and exciting to see use of so many of the tools that we've seen and been successful in other parts: values clarification, provider share, etc. That's fantastic. So we do have some questions in the chat, and yes, please go ahead and post your questions in the chat for all of our panelists. And I want to thank all of our panelists for being so concise in your presentations, so that we do still have time for discussion despite our technologically delayed start. there's one question about men that I want to get to. Someone asks, could you discuss how gender interacts with this issue? How do male partners experience abortion services, shame, stigma, and if it has been studied? So if anyone on the panel might address that, Leslie or any of the others. And then there's some questions specifically for you, Leslie, around has it started now? How can people learn more about it? Is it only going to focus in the UK, et cetera? So I think you might be able to see, Leslie, the question there in the chat for you.
Okay, I can't actually see the
chat. Okay, let me just read it to you then.
Can I jump in on the men question, Anu?
Yes, please, Karen, go ahead on the men.
Well,
and then Leslie,
and Leslie can have a look at the questions. So my PhD work was actually on men as fathers, so I kind of feel like I have a crossover between gender in terms of how it relates to women's health and how it relates to men's issues. But in relation to that question, none of the data that we looked at, because we were a secondary analysis study, could shed any light on that. So we didn't have any accounts from male partners, but I know there was a small amount of research on this, just, a couple of papers that I'm aware of about how they experienced it. But I couldn't say that we have data to speak to that, I'm afraid, but it is something that I'm really interested in, is how gender interacts with this whole thing. I would speculate that the men probably didn't feel as stigmatized as the women going through the experience of having the abortion for themselves.
Thank you so much, Karen. So Leslie, a question about the NHS services also, and how do NHS services go about booking a workshop? Sounds excellent. Is it free? And then the question around whether the charity is only going to focus in the UK context.
Yeah, okay. So at the moment, we are just working in the UK, but we're working very closely with another sort of campaigning activity, which is My Body, My Life. So our website will be linked to My Body, My Life website, and My Body, My Life can be much more global than just the UK, and in fact includes quite a lot of links to other storytelling organisations. How can the NHS services go about booking a workshop? Sounds excellent. Is it free? Well, at the moment it is free, yes, and people can please get in touch with me, because we're setting up and we're really doing we've got some funding to pilot these workshops. In the end, we hope that organisations will be prepared to pay, not a huge amount, but be prepared to pay for the workshops, because that's one way in which we will actually finance the helpline, which will be a free helpline. So obviously fundraising is going to be one of the major things that the charity is going to have to work on. And we're hoping that some of these workshops, so there's the values clarifications workshop, which is from IPAS, and we're getting training on how to do that. And then the provider share workshop, which actually some of my colleagues are being trained on this afternoon, is also something that has been practiced elsewhere and is proved to be very successful. So yeah, we're going to be prepared to do both of those, not for very much, but hopefully to finance the helpline.
Terrific. Thank you so much, Leslie. I do want to go back to Rishita's question, because it's quite excellent, I think, and interesting and relevant for this conversation. I mean, essentially, her question is, we've been largely focusing on the interpersonal levels of stigma, and how do we theorize about abortion stigma at the structural level? And how does it manifest itself through health or social structures and influence in abortion provision and care? Let me just offer one thought on that, Rishita, and then I want to, definitely want to hear from the panelists. I think this actually is understudied, and one of the reasons is that it's fairly difficult to figure out how to design a study to measure the impact of structural impact, to measure the structural impact of policies and health systems. But I'll give you an example, which is very real and present for us at IPAS, which is the Helms Amendment. The Helms Amendment is an amendment to the U.S. Foreign Assistance Act, which has essentially been interpreted as a total ban on the use of U.S. foreign aid for the provision of abortion information, care, counseling, everything. This is the only medical procedure in all of U.S. foreign aid that is targeted in this way. And it has resulted for nearly 50 years in exclusion of abortion being funded by the U.S. government. So to me, that is very much abortion stigma at a very large macro policy level. Of course, the gag rule is similar, and recent data from the Guttmacher Institute has actually helped to quantify the impact of the Helms Amendment. And I think more of that kind of work is what we need to really think about. What is the impact of this? And the Guttmacher Institute has said that, you know, if the Helms Amendment was rescinded, just in their very small analysis of not, you know, the whole world, but in 33 countries, something like 19 million abortions, unsafe abortions, could be averted. So that's big. That's big policy impact. So that's just one example that I can think of immediately. Who from the panel would like to take on this question from Rishita? Fiona?
I can make a start,
Please.
I mean, this is a really, really big issue, and something that other people will chip in on, I'm sure. But you're right, we do focus in this research on interpersonal and experiences of stigma. But I think it's absolutely right. These experiences and these interpersonal accounts wouldn't be there if it weren't for the structural foundations of abortion-related stigma. And I think obviously gendered relations are very important. And obviously, you know, going back to gendered relations, thinking about the family, thinking about women's role within the family and within society, and what's expected of women and what they're expected to do. And one way in which this does actually transpire as a structural issue within the health service is that this is somebody's going to say it isn't, but I think it is, the only medical procedure in which you have to talk about person-centered care, and it seems as though you're talking about something new. Person-centered care is something that is being striven for in virtually every aspect of health delivery, but it's treated differently. And all the concepts that, you know, we think we take for granted that should be part of a normal part of reproductive health care, the fact that it isn't, and that it is exceptional, that it has its own set of regulations, is a very structural barrier to it becoming normalised within the healthcare system, and that's obviously not just in the UK. We could go on and on about this.
Yeah.
I'll let some of the other panelists come in, and maybe somebody else from the audience.
Fiona, please go ahead.
Oh, Fiona, you go.
I was just going to say we had some examples in the abortion as a workplace issue study where the participants very much, you know, labelled the stigma as emanating from church and state, you know, and they're participants from the Republic of Ireland and Northern Ireland, both before we have the legislative change in both jurisdictions. So it's something that was very much a theme there. We haven't actually got down to analysing all of the data. I mean, I'm meeting with the research team at the minute to look in particular at the interaction of the anti-abortionists who were part of that project and the ones who were not anti-abortion. So we're looking at the minute that interaction, but it is something we would like to come back to. And we have a very current example of the blockages. I mean, in Northern Ireland at the minute, we actually don't have commissioning of services from the Department of Health. So that means that the staff who are delivering the services are very much doing it on an interim basis. They haven't been officially commissioned. And it means that they're only able to offer early medical abortion. And so anyone who needs surgical or beyond that is you know, very, very restricted. So I think the whole issue of structural blockages and that stigma that's associated with that is very present.
Yeah, absolutely. Thank you. Sam, would you like to comment on this question as well?
I don't think I've got anything to add at the moment. Thanks.
Okay. Carrie?
Yeah, I would probably just add to, I guess, partly what Leslie was saying about the kind of health service provision side of things. I guess something that we saw in a lot of the data with health professionals is just the amount of work that individual health professionals have to do at the front line to really provide the kind of person-centered care and the kind of abortion care that they want to provide, almost in like a real tension with the overall structure of the health service that they're working in, that does exceptionalize abortion, that doesn't treat it as routine care. So it just generates that extra level of work for individuals who are having to kind of, you know, fight against that almost, and do a lot of extra work just to kind of get to a level where with, you know, with any other kind of service, that's where you know, they would be wanting to be. And I think the only way that you can change that is a kind of higher level structural change in terms of health service, in terms of policy. I mean, something that we did have in Scotland was a sexual and reproductive health policy framework, which did at one stage have a specific focus on stigma and providing destigmatized or stigma-free healthcare provision, sexual healthcare provision. And I think the kind of stigma combating side of that has maybe fallen by the wayside a little bit because of the difficulty, Anu, that you touched on already in measuring stigma. It's something that's really, as a kind of outcome, is really difficult to measure, or you know, destigmatization. I think there is a real problem there in the kind of tension and the pressure that it puts on individuals in their everyday work versus the system that they're working within.
Yeah, thank you for that. I think we do see it in so many levels, stigma, and you know, that's certainly at the healthcare level, you do see it in things like who's permitted to provide abortions, where are they permitted to provide abortions, what form of abortion care are they allowed to provide. You know, the clinical protocols, which, you know, what Sam was referring to in terms of the telemedicine work, that's where you see a lot of stigma manifest in terms of wanting to restrict or very much curtail the provision of abortion instead of making it as widely available as possible. So I know we have a number of other questions here. There's one that I was that for panelists about whether they could comment on countering negative myths around abortion, such as abortion causes PTSD or abortion causes future infertility. Who among you would like to take that one?
I mean, some of that negativity is actually misinformation or disinformation. Disinformation is sort of malicious. And I think, you know, we all have a job to do there to keep on countering it and correcting it and bringing people back to what is evidence-based.
Yeah, exactly. I mean, I think it's an interesting question because abortion, like some other controversial issues, for example, climate change, has an entire discourse that is actually anti-scientific. Vaccines, you know, these discourses have been allowed to proliferate, and they've also been present in established and accepted medical journals. So in some ways, our peer review process has broken down by permitting this kind of literature to enter into the discourse at all. So yes, I think we do need to counter it from that way, but I also think that there are opportunities, and maybe Lesley can speak about this in terms of storytelling and you know, other ways of countering these sorts of myths. Lesley, would you like to comment on that?
Yeah, I think that's very true, and I think that we have to tackle those myths at a whole number of different levels, and there is obviously the myths and the misinformation that is peddled by anti-choice activists, and generally we do respond to those sort of robustly as soon as we can. But I also think that what we need to do, and this is something that we have done with My Body, My Life, is to go right back to sexuality education and sex education in schools, and we have to start busting the myths from the very beginning, you know, from a very early age. So one of the things we've also done is we've worked with Brooke, Young Person's Charity, which has got CSC, which has got relationships, sexuality education materials on abortion into schools now. And, you know, and one of the things within those materials is actually tackling these myths. Myths are often around fertility, around different illnesses, you know, and just basically providing information that people need to know.
Yeah, thank you for that. Carrie, there are a couple of questions here for you in the chat. One is about asking, Rebecca Blaylock is asking whether you or anyone else is actually aware of any work that's being done at the financial costs of exceptionalizing or stigmatizing abortion care in terms of the extra work that is involved by providers that you were mentioning. And then I'm heading back up to the chat. There was a question, I believe, from Joe Strong about the samples for the secondary qualitative data analysis. And I think that was directed at you. Do you see that one, Carrie, up there?
Yeah, I think so. Oh, I did see it was going.
Yeah, so I was wondering whether you did an analysis / mapping of the samples. Yeah, could you take those two questions?
Yeah, sure. So in terms of an overall mapping, we did, and Karen can maybe say a little bit about this, but we did do a lot of initial kind of scoping work, partly to see what we could do with the data, because we did end up with such a huge volume of it. I think it's a really good question, and maybe something that we need to think a little bit more about, and what we could think a bit more about in terms of actually the voices included, because as much as we did have a broad range, the Scottish studies, or the Scotland-based studies, were mostly with women who had recently had abortions, for example. Leslie's studies, the sort of English-based studies, were, I think, a bit of variety of recent experience, but also attitudes. The Northern Irish data was more kind of focused on attitudes rather than individual experience. So there was a bit of a mixture there in terms of what we had of sort of more attitudinal, broader data and like individual experience, which was partly what we were trying to grapple with, and how you actually put all that together in a coherent way, without writing a sort of 200-page report. But yeah, I think that's something that we really need to think a little bit more about, and in terms of any kind of research, qualitative research in particular, are there particular voices being centered and being amplified in particular ways that the others maybe aren't. I think that's the difficulty sometimes when I'm trying to think through if we're interpreting what the sort of absences might be in what's being said, as well, because obviously we can only access the voices that we're hearing in terms of the data that we have from the studies, and not the gaps that are there. I'm not sure if that answers the question.
And what about, it does, what about the question of the financial costs of doing the extra work?
I think that's a really interesting question as well, because I suppose if you're thinking about making a case to at the level of kind of health service organisation, then the sort of economics are a key way of getting to that. It's not something that I'm aware of any research having been done, certainly like in a UK context. I'd be really interested to hear if there was, though, because I think that would be a really useful way of kind of making a case for that kind of change.
Yeah, we did a project years ago on the economic costs of providing abortion at different levels of the health system and by different types of providers, but it's a little bit different than the question was about asking about extra work. I think there are a couple of questions here, Sam, for you. One from Maria Luisa Banfi, who's asking, I think she's asking this about your the telemedicine. So she wants to make sure that ultrasound is not being done. If it's not being done, then how is gestational age being assessed?
Yeah, so what I said was that it's not routine, so that means that not everyone has to go through with it. So what the gestational age is based on a certain last menstrual period. If there's uncertainty or risk factors for ectopic pregnancy, then a scan is done and people come into a healthcare facility.
Okay, great. Thank you. And then we have some comments here around abortion care in nursing and midwifery education. There's a whole lot of comments around education and the importance of medical education, which I think does highlight on this. Does anybody want to comment on that? Leslie?
Yes, so there's not a huge amount of work done on this, but there is an organisation, Doctors for Choice, that I would encourage anybody to look towards for work around training and abortion and thinking about what is needed in terms of education and training for health professionals. And I'm pretty sure that they've got a couple of papers coming out. I think that they've got one paper that is out shortly in BMJ-SRH, if it's not already out, and hopefully one coming out in about 6 months, which is really looking at the training that medical students have received and also their thoughts about why it would be valuable for them to have that training, whether or not they go into practice abortion with themselves, but whatever aspect of the health service they go into.
Great, thank you for that. Yeah, we have at IPAS, we do have some experience with medical education, and we actually were involved in introducing abortion care in the nurse midwifery, all of the nurse midwifery schools in Nigeria and elsewhere. It is pretty, it seems like an obvious and easy thing, but it's not. It's not easy, and it is not a panacea. It does not result in providers that are somehow providing care with great dignity and humanity, as Sam mentioned. It doesn't always work that way. I am very conscious of the time and that we are running out of it. So to my panelists, do you see any other questions that we should get to before we wind up?
No, but I see a lot of people very helpfully putting in links to papers
Yes.
that are dealing with some of the questions that we're discussing. Yeah. So that's great.
Yes.
Helpful.
Yeah, it's really
absolutely
helpful. Thanks, everyone.
Yeah, exactly. This paper, this systematic review on economics of abortion by Ernestina Coase. Yes, that's excellent to have it in there. There was one question about, which I did not fully understand, regarding systemic obstructions and stigma. Any thoughts on role of Certificate A requirements in the Abortion Act itself?
I mean, I think that's referring to all the paperwork, red tape, etc., associated with the abortion laws, and that's why we're advocating decriminalisation, because you don't need all that stuff. You just need normal regulation as per any other type of healthcare.
There you go. That's a perfect note to end our session on. We don't need all that stuff. We just need normal abortion care as part of routine medical provision of care. Thank you. Thank you for that excellent ending, Sam. So I want to thank all of our panelists. I want to thank our attendees for patiently managing with the technology and for sharing so much of your wisdom and knowledge with all of us. And certainly I want to thank Carrie and Karen for their leadership on the SASS project itself. Please go to the website. You will find more information there, including very handy and short briefs if you don't have time to read the papers. But it's a wealth of information that I think will be useful to all of us for years to come. Thank you all so much for your attendance. Take care.
Thank you for chairing.
Thank
Anu.
you.
Yes,
Thanks,
thank you
Anu.
for sharing. It was
Thanks,
very
everybody. Thank you.
okay.